Okay, good morning, everyone. Thank you so much for joining the Ohio Chapter American Academy of Pediatrics for our Lead-Free Ohio training. We are excited to have Dr. Joel Davidson from the Akron Children's Hospital here today to present. Just a few housekeeping items before we get started. Please keep your videos off and your lines muted. You are welcome to use the chat box to ask questions, interact. Dr. Davidson will have us use it to ask a few questions at the beginning, and you're welcome to add any comments or anything throughout the training, and he will answer questions at the end if there are any at that time. We also want to thank the Ohio Department of Health for their support with this training and this program. We have resources available and a lead toolkit, and the link to register is in the chat box. So please check out our resources, our recorded trainings, and our lead toolkit. And we will also have a 1CME available for this training, and a survey will be sent out on Monday to receive that certificate. If there are any questions at any time, please feel free to send me an email or ask me in the chat box, and we will go ahead and get started. I will pass it over to Dr. Davidson.
Good morning, and hello, and thank you for joining us. The Ohio chapter of the AAP has been a great leader in helping Ohio's children as it relates to lead, and I think there's we have amassed a great amount of excellent resources. I'm going to build on some of the previous discussions that have been happening within this important work. So today I'm going to be talking, I'm Joel Davidson. I'm a general pediatrician from Akron Children's Hospital, and I am one of the regional experts in the issue of lead exposure and lead toxicity in children. I'm a tertiary care provider, meaning people refer to me within our lead clinic here at Akron Children's Hospital, part of a larger team that I'll talk about how our team is structured as part of this discussion. But today we're going to be talking about identifying, improving, and educating, addressing lead exposure risks in the primary care setting. I wanted to start off today by asking those of you who are participating to just let me know what your role is, what brought you here to this talk, why you're interested in this topic, and maybe something that you're interested in learning. If you could just put that in the chat, that would help me get an idea of who all we have gathered today, and really what we'd like to accomplish, and what kind of drew you to this discussion. All right, so far we have, okay, great, now they're coming in. Thank you very much. We have some advocates, we have some providers, we have some home health workers, some Help Me Grow people. Awesome, so our audience in this world of lead really does run the gamut. And again, these slides will be posted online if you're joining us online. After the fact, we welcome that you're interested, that you're thinking about this problem, and that you're advocating in whatever role that you provide in helping Ohio's children. Today, we're going to discuss really three objectives. Quickly going to identify some sources of lead and the risks of lead exposure to children. And we're going to spend a bulk of our time talking about the specific quality improvement work that has been done both in practice and within the electronic health record here at Akron Children's Hospital, and how we've used those tools to increase our screening rates and address kids that are exposed to lead. And then last, we're going to review some available resources for communicating with patients and families around the issue and topic of lead. I wanted to talk about these items in the context of recognizing that there's been some excellent discussion from many colleagues throughout the state around this topic. So I do refer you to make sure that you're paying attention to some of the previous discussions. And I'm trying to not repeat a lot of the things that have already been said within this forum. I do have a few things that I just want to let you know about. I'm going to talk about a little bit of research that I started off some of our work in conjunction with Kent State University, and that work was funded by the Akron Children's Hospital Research Foundation. Later on in my discussion, I'm going to talk to you about some of the content that we've developed that helps providers and community members understand the issue of lead and what to do about it. And that work was supported by the Sherwin-Williams Company. I do say that in full disclosure, but also recognizing that they really had no input on the content of what we developed. They really gave us the funds to make that happen and let us put together those materials ourselves. Everyone that's around, that interacts with kids around the topic of lead kind of has heard about the sources of lead, but I think it's important that we frame some of our discussion around where do we find lead and kind of where does it come from. Most of the time you kind of think about lead as being in paint, but it can be in dust and in water and soil. Ohio has a large amount of previous areas that were highly industrialized, and when lead was being used as part of that industrial process, it could get into the air and settle into the soil. We used it, of course, in gasoline. Leaded gasoline was, present in times before 1980. There's also some sources of lead that people bring with them from another place. So, some immigrant populations may bring a toy or an object or a family artifact that has lead in it. Some toys have lead, old pottery, even some current glazes or things like that. And then there's still presence of lead exposure within certain occupations, especially in like recycling or kind of quote unquote lead smelters. There are some industries still to this day that we have high risks of exposure. Varnishes, somebody put in the chat, yes, old furniture refinishing is one of the hobbies that we think about. Fishing lures, hunting supplies, the dust that's created from some of those pieces, leaded glass, maybe some jewelry, even artificial turf has been described as having some lead in it throughout the history of how manufacturing worked in those areas. When we look at some of the previous studies around lead and what actually contributes to kids' lead exposure, a lot of those are primarily within the home setting, and that's where we focus a lot of our effort and discussion. When in this study from 2016, lead dust was the primary contributor, with water and soil being closely behind that. But basically, there's lots of different opportunities for kids to be exposed to lead, either in their environment from some kind of a way. And so how do kids get lead into their body? It can be ingested or inhaled. You can kind of see the picture of the dust that as the sunshine comes through. In my area, sunshine is not coming through our windows this morning, but kids are breathing in that environment, and they're moving around on the floor. Kids, obviously around 6 months to 9 months of age are starting to kind of put those knees under their bellies and start to crawl around the floor and putting things in their mouth. A lot of hand-to-mouth behaviors. But as kids get even older, some kind of interest in swallowing things that are not food is also an important way that they get exposed to lead. I like the picture on the left also because it reminds us that really, these are frictional surfaces. The opening and closing of that door thousands of times, even if that lead was covered up with new paint that doesn't have lead in it, that friction and also with windows really does create that dust. And it doesn't really take that much lead to get a child exposed significantly. So of course, there's no lead, no safe level of lead. Lead has no actual purpose in our bodies, but we can see some cognitive defects in children associated with blood lead levels less than 5, especially in developing brains in kids less than 6 years of age. And Dr. Newman has talked about this before, but this is an irreversible change. And so, really the beginnings of this is that in order to prevent all this, we have to prevent the exposure in the first place. We do see some adverse behavioral effects, mostly attention, impulsivity, hyperactivity, executive functioning skills. And that's really what we're mostly worried about in preventing that, those effects as kids get into that lower school aged and beyond in their development. So I want to talk a little bit to this group about my journey. One, I became interested in lead because it was important to my clinical work. As a practicing pediatrician, I work in an area with a high rate of newcomers, resettled refugees, some people might call them. And in that clinical experience, I started to just see closely after residency that a lot of these patients that I was seeing had levels in the 20s or 30s. And I, maybe similar to some of the other providers on this call who have had those results come through, kind of start to say, well, wow, what do I do with that now? Practically what happened with that was that I developed an interest, started studying a little bit about what we knew about our own lead responses within our hospital system, using our hospital data. And then because of interest, was able to assemble a team, transfer the team really within the organization to primary care. Previously, it was managed really by a group of hospitalists that had to borrow a nurse, and we were able to kind of say, we have the nursing staff, we will take on those responsibilities and really build that team. But a lot of that came out of the research interests that we had. And so, research does a lot of things. It helps you define the problem. It helps you identify specific areas. It helps you give an idea of where your own community is. And it garners interest, and that interest then kind of got the attention of our organization. I had the opportunity to have my lead clinic interests bud into someone saying, hey, we want to really start to do some population health work within the electronic health record. And then I was able to, along with a lot of other people, develop some interventions using the electronic health record tools to make this process easier. And now I am part clinician, part lead expert, and part informatics scientist to help improve quality for lots of different things throughout the care that we provide children at Akron Children's Hospital. I show this slide because it really helps illustrate that story pretty nicely. When I graduated residency, I used to have a piece of paper that had all the criteria of what made a kid high risk for lead. You turn the paper over and you could look at the high risk zip codes and try to decide based on that information whether you tested the child that was in front of you for lead or not. And that is really the underlying layer of the slide on the left-hand side, where the high risk zip codes are red, the medium risk zip codes are in kind of a brown, and then the lower risk zip codes are in the yellow. And that information is available, and I appreciate the work that has been done, that had been done prior to this, to really even get down to that level where in Ohio we do know where kids are at higher risk, and we've kind of started to stratify that risk in order to provide the appropriate care. The blue lines represent our system from 2012 to 2014 of where geographically, specifically, we had lead test results for children in our system at Akron Children's Hospital. And then the slide on the right, we really wanted to drill down and kind of look at specific neighborhood level influences. And this map that we developed in conjunction, again, with some mapping experts from Kent State, allowed us to really get down to the neighborhood level. Another part of this research work was to actually try to test the hypothesis to see if we could identify risky homes based on external features of a house. So this was some of the expertise that the geospatial experts brought with them. And really that was the focus of the specific research, was not just specifically where are these houses, but could we identify a model that we could say, all right, even before somebody moves in somewhere, could we even predict which houses might be at risk? And we were able to kind of make that connection. The other pieces of our work clinically that connect to lead is that we have a really strong and robust medical legal partnership. And so this is a connection, community connection that we've made within our office to lawyers in our community that are advocating on behalf of patients and addressing health harming legal needs. And this schematic and then the following slide was developed really in connection with our medical legal partnership colleagues. And what it did for me was it helped me put together just this overall community approach to how could we potentially address the issue of lead. I've had a couple mentors in my life that say, just put things in the context that makes sense to you. And this is my representation of the problem of lead. And it's not perfect. There's probably things that we missed on this, but we tried to break things down in terms of primary, secondary, and tertiary prevention. And by that, I mean primary prevention means that the child's not exposed to lead at all, that we reduce that exposure, eliminate that exposure. And that's our main goal. The secondary and tertiary prevention efforts are really around secondary prevention being detecting early disease and intervening early. So those might be the lower lead levels and making sure that we're talking about that and mitigating any of those potential risks early on. The tertiary prevention for lead, in my mind, again, it's an irreversible exposure. Exposing a child to lead is really changing that brain forever. But it's more, what are we doing after those levels of poisoning or damage to mitigate the downstream effects for that child. And so that's kind of that tertiary prevention is managing that disease state, avoiding further complications. So those, kind of see our interventions or potential community-based interventions mapped here. I also like to put things into like simplified schematic workflows because that makes sense for me. And so here we kind of have another kind of idea of the specifics that are happening with the different players between home-based, school-based, medical-based, and public health-based interventions. And really, we're going to focus some of our discussion today on the specifics of what we've done within our medical setting at the hospital and within our clinics on this medical branch. But I'm not ignoring in this discussion the influence that we have in some of these other places. I do know that the schools have a large role to play in this work. They're probably an often forgotten about or not discussed as much part of this. Public health, certainly, the Ohio Department of Health and our public health system in Ohio has been a great leader, especially as we start to codify some of those rules and regulations. So in Ohio, we've decided that it's important to screen kids at 12 and 24 months, focusing mostly on high-risk individuals, as Medicaid status is a high-risk group. Anyone on Medicaid really should be screened at 12 and 24 months. Anyone that lives in a high-risk zip code, and that's, again, what I was referring to earlier, flipping that page over, is maybe some of you are even still doing, trying to decide, does my child live in a high-risk zip code or not? And then, of course, there's other risk factors that are often difficult to assess within a clinical setting. And again, Dr. Newman has talked about this in a previous talk related to the effectiveness or not effectiveness of kind of screening questions. This slide is old, so less than 5. As many of you know, the level threshold of concern is now at 3.5. Ohio Department of Health really our group and lots of the educators around the state will be coming out with some new guidance around what to do with the new level of 3.5 and higher. So I want to shift now and talk a little bit about quality improvement and kind of our approach to quality improvement at Akron Children's Hospital. And we really rely on the IHI approach, and basic quality improvement is like figure out what area you're working on. Okay, we're working on an area of lead, and then getting specific with that with a SMART aim. And so our SMART aims for the work that we chose to venture on related to lead screening, which really came out of our own evaluation following the research that I did to say, are we really doing a good job? Are we really following the guidance that's codified into law? Are we really identifying all the right patients and are really testing them? And what can we do to improve that? So our SMART aims were to increase our percentage of 12-month patients that got screened from 71% to 95% within a specific amount of time. And then for 24-month-old patients who are on Medicaid, who live in a high-risk zip code and have positive risk factors, i.e. are at risk, got tested, and from 41% to 70% by a specified amount of time. So it's, as you're maybe thinking about pursuing some improvement in the work that you're doing, whether if you're a clinician, it may be around kind of this screening process and this identification of patients and what you're doing in your office to address those patients that you've identified to be exposed to lead. Or if you're even someone that's in a setting like some of our participants that are home health workers or early intervention specialists, what are you really hoping to accomplish with your population of interest? And then specifically, what do you think is the main thing that might be driving that improvement? And identify what those like primary and secondary drivers are. And so I put here our simplified key driver diagram, and I'll show on the next slide our more in-depth key driver diagram for reference. But the whole point of quality improvement is to really start to narrow in on what areas that you're going to focus on those areas, demonstrate some improvement, and then continue that cycle of evaluating and moving forward on the next cycle of improvement that really is going to all support your SMART aim and get you. So here's a description of our, here's the descriptive version of our key driver diagram that we use to guide our work in this project. And I would also say that key driver diagrams serve the purpose of putting some of your thoughts down. They're really designed to be workable, livable documents. So you're allowed to put things on, take things off. Hey, I have an idea. Let's put that on as an intervention. Let's kind of see if that intervention, we try it, it didn't work, we can remove it from the list of things that we're thinking about. But feel free to use this model that we created in our key driver diagram for your own work if it's helpful. And I hope that it is. I'm going to move now to talk a little bit about what kinds of things that we did within the electronic health record that were really helpful to make sure that we were meeting the aims that we set out to achieve. I will say we made a decision as an organization around the 12-month check, and this is where we really are probably kind of look at the recommendations. 12-month-old kids that are at high risk, and that means that they live in a community where more than 25% of their population has a risk of older homes. We have a very large region, cover large swaths of northeast Ohio, and it's pretty difficult to decide whether a kid is spending significant amount of time in a high-risk home, i.e. with their grandparent or a caregiver or something like that. And we made a decision based on what we knew about our housing stock in that large geographic space and the potential risk of not identifying a potential exposure, especially based on some of those hobby-based kinds of things, that we were going to take a look at every kid at least once and do universal screening at 12 months. This is our own decision as an organization, but I just wanted to provide some context of why we made that decision. In our electronic health record, we have the ability to use some standardized sets of orders for different various visits, and those are in our system. We call those SMART sets, and we designed, our providers really do use these SMART sets with high reliability within specific visit types. For example, for our well checks, providers are going to use those standardized sets of orders about 95% of the time for any of those given common well check visits. So we use this knowledge of high utilization of these defined order sets and collections of them to insert the right kind of order into the provider's workflow and make it automatic when we wanted them to receive, when we wanted kids to be tested. Now, within our system, we were able to do this. We were already able to do finger blood draws. Our nursing staff and provider staff was already able to order those things. We had a mechanism to be able to get a test result and deliver on that screening. If you exist in an office that may not have some of those capabilities, your emphasis may be a little bit different and maybe even a little bit more upstream than where we were. We did have to make some changes though. even within our lab ordering system, before we started this work, we just had one test. It was called a lead test. And you typed in lead, and if you wanted a venous sample, you had to put in venous sample into the comments. This was very hard to track which patients that were high that we wanted to have venous confirmation for, which test we were actually performing. And even sometimes the lab would kind of mess that up a little bit, and we would order a venous sample and it was done in a capillary, and there was a lot of complications for that. So one of the first things that we did, and it's actually not terribly simple because you have to think about what tests are outstanding, and notify the people that have an outstanding old test as you convert to the new ones, is separate those from a screening capillary evaluation to a confirmatory venous sample. And this is, as I look around at colleagues, and I've talked about this in national settings, is one of the bigger problems that people have. So you have to work with your lab team and say, we need 2 tests so that we can monitor and track this over time. So in the 12-month SMART set, somebody comes in for a 12-month visit, they will get a lead test most reliably, most of the time, because people are using that. And we did some evaluation, I'll talk about that a little bit later, to make sure that people weren't unchecking those, because that was a little bit new for some of their patients. The other thing that we did was we also built the computer to look back to say, if patients came back in the future, we wanted to make sure if they were 30 months or less, and they came in and they hadn't had that first initial evaluation with a capillary lead test, that they got that done, and we made sure that the computer knew to catch those patients up. And actually, as we look at our data, the patients that didn't show up as their scheduled visit probably have something different about them, and we do find lead rates a little higher in that group that we're catching up. So how do we do? We were really quickly able to overnight, with turning on the tools, really drive some drastic improvements in our lead screening rates. And so in the beginning, we were about 70% of overall patients that came in for their 12-month checkup. We did notice, that there are some influences on other things. Flint was in the news, if all of you recall, early part of 2016, and that did have an impact on our provider screening rate even before we did anything. And you'll also see on this run chart, which is a way that you can keep track of your metric outcome within your quality improvement work, that lead rates, screening rates started increasing even before we turned on the tools. And this is called the Hawthorne effect, where some external forces, people knew we were talking about it. We were developing some things, we were changing a few things. Even that energy will drive some change in your work. And we have, just for your reference, this only shows through 2017, but we continue to monitor this, and we continue to really be at about 95% on our lead screening rate for 12-month-olds. The 24-month-old story is a little bit different because we used risk-based screening for this 24-month group. And so that means that really at 24 months, we were only looking at kids who were either on Medicaid or lived in a high-risk zip code based on their demographics in their chart, to automatically check that lead test, capillaries test at those visits. And so that was a much more computer logic, a lot more work that went into making sure that we did that correctly. But what we eliminated was providers having to do that cognitive load themselves, so that they didn't have to go back and look at what the patient's insurance was. They didn't have to look through what we now know is like 512 or 510, something like that, zip codes throughout the state to see if their patient fit into one of those zip codes. It's just an inefficient process, and we let the computer do what the computer does well, and help the clinicians do what was appropriate more often. And we can see that within all patients, and this is why our goal here is not 100%. These are in all 24-month children. We didn't really know before we started this work how many kids were on Medicaid and how many kids fit into those high-risk zip codes, but we knew how many lead tests we were doing at those areas. And by turning on the tools that does that evaluation, then we can know that the amount of risk in our population is around 70%. And as you can see, when we turned on the electronic tools that we built to make this more efficient, we were able to achieve much higher screening rates in the kids that we really wanted to know about. I'll draw your attention here to the dip that happened. This is one of the values of identifying what metric that you're interested in that helps support your global aim and your goals within your specific aim, is that you start to see that to drop. And once we started to see this drop, we started to think, like, what's happening? And what was actually happening was that this change was different for clinicians, and they were actively going into those smart sets, hoping to save more time, thinking that their child wasn't at risk, and they would uncheck that lead level. And so what we did was targeted some communication to specific providers who were performing that unchecking ability. And we were able to do that all kind of because of the electronic health record integration, and really start to change the trajectory of that screening rate at the 2-year mark. So what about kids that we've identified to be high? The second arm of this, so I just got done talking about the screening, the initial evaluation of children that come into the office. But what about the kids who come into the office, they get that evaluation and they're elevated? And right now, again, that's over 3.5. And so the next time that a provider goes into that chart, they will see, hey, this child's lead actually is high. You might need to do something about it. So in this example, the previous order of the lead test was 10. Again, we didn't know if that was a capillary or a venous, but we knew that we wanted to perform a venous confirmation for those patients that have been identified as being high. And what the provider then will do is open up another set of orders that is specific for kids that have an elevated lead level. And there's a lot of clinical decision support, some supporting documentation that kind of maps with what the state guidance is that says, hey, if your level is between this and this is what you need to do. And so that takes away the provider's reliance on memorizing what those recommendations are, and puts that information right into the workflow where they need it, which is, hey, this child's high, this might be what you need to do with it. Inside that order are some other things that a clinician might perform on a kid that has an elevated lead level. For example, you might get a ferritin to assess for iron deficiency. You might get a CBC or a hemoglobin if you didn't already have one. You might order an abdominal X-ray. You might make a referral to the lead clinic. You might make a referral to the medical legal partnership. And that all kind of puts that information where they need it again in that set. The other thing that we provided, built for our providers, is a evidence-based collection of history questions that they can then document the correct history around these kids that now have an elevated lead. And so those are things like, where have you been living, and where is what is a little bit of history about where you have lived in the past, or where you spend some extra time. What are some of the hobbies of the people that you spend time with? What are your parents what jobs do your parents have? And then also allowing the provider to quickly and easily document things that are related to the guidance of those patients. Are we talking about certain topics as it relates to lead? Are we talking about moving out of your home while remediation is happening? Are we talking about washing your hands before you eat, or keeping your shoes at the front door? Are we talking about wet wiping down counters and windowsills and things like that? So all of that information is available in the note writer, the note template that we built for our primary care providers to be able to utilize before they even come as a tertiary referral to the lead clinic. Still, to this day, we do provide a large function of our tertiary lead clinic is to provide education, education to referring providers, education to families who have questions, and really be a support. I don't have we have some time allocated throughout the month for the patients that are the highest, and those are primarily patients that we're thinking about chelating therapy for. And so we have a centralized lead clinic, and that lead clinic is myself and a pharmacologist, toxicologist, a social worker, coordinating nurse, a medical legal partnership representative, and a neuropsychologist. Our neuropsychology department has been very helpful within as members of our team to do some initial assessments for kids that are coming through to us, but also being available to look at some of the specific cognitive effects on kids' brains. One, when kind of close to the time that they're exposed, but also at times of transition when kids are moving from elementary school to middle school or middle school to high school. There was a question in the chat. I think it's a very good question. Are they available are some of these sets that we've built available in a toolkit? If you are working with Epic and you have connection to the Epic user web, my team has written a white paper around how you might build your approach to lead screening in a similar way that we've outlined. There are some decisions that you have to make as an institution. You can't really just download our build. It has to integrate into some of the systems that your system uses. And there's a never-ending set of challenges as it exists to make that happen. But for those of you who are on this call or listening to this, if you would like some help or some guidance on that, my email will be at the end of this presentation, and you're welcome to have some more discussion around what it might take to do something similar at your organization. There's another question about how long it takes for kids' lead levels to leave their body. This is one of the most common questions that we get from families. How long is this going to take to go away? That answer does not have a linear relationship ever. And it really depends on the level of burden, the body burden of lead. So initially, lead is in the blood, but lead quickly gets distributed to lots of parts in the body, and it can be stored in bone and liver. And if it's a high amount of exposure for a long period of time, the rate of decline is much slower. So a lot of work that we're doing is to try to level set the expectations about how we can get this lead level down, but really focusing on the environmental influences that child has within their environment and getting them out of that area. That's easier said than done. There's lots of approaches that you can take to support and advocate for families that have this identified. The other thing that I would like to say in this context is, a lot of families come to us feeling very guilty that they've exposed their child to lead. They start to do some research. They look online, and I really try to have that discussion to identify that that's a real emotion, but that we need to look at moving forward about what we can do and how we can possibly make things better. And parents are excellent advocates for their own children. And it's our role as the people in this group that we need to stand up for those kids to allow them to have a voice. Fully recognizing that the medical model that I'm presenting here is finding the canary in the coal mine, and what we need to do is prevent people from being exposed in the first place. And so one of the ways that we address that, and I will say that the materials that I'm going to present because they're part of my story. They're part of our story as we've approached the problem of lead. But it actually precedes a little bit of the information that was presented and that was referred to early on in the chat that are available through the Ohio chapter of the American Academy of Pediatrics. And the wonderful colleagues that have put those resources together. This is our version of some resources, but Ohio AAP has their own versions at Lead Free Ohio, ohioaap.org/leadfreeohio, that I think are also very good. One of the things that I talked to you about was that I take care of a large number of families that are newcomers to our community, have resettled, and the resettlement process kind of by definition puts families into our most vulnerable housing stock as it relates to affordability. And so I showed you the map first off in the beginning of this presentation. There was a large amount of lead exposure in the north sector of Akron. And that's really what we call the North Hill community. The North Hill community is a very diverse geographic location that a large number of newcomers are resettling to. And North Hill High School, which is there in North Hill, has the most languages spoken than any other high school in the state of Ohio. And so we have a challenge within our work to communicate to families that don't speak English. And a large number of these resources are video-based or pictorially based because of some of those language differences and also literacy differences in general. So I'm not going to show this video today. If you're interested as a relation of participating in this talk, going to this, you can get to that just by going to akronchildrens.org and /lead, and under resources, you can get to all of these videos. But we translated 2 videos. One, how do I protect my family from lead? And then a second video there's an introduction video, and then a how do I protect my family from lead resource. And those are available in 6 different languages, in Spanish, in Korean, in Arabic, in Nepali, and English, and Burmese, which are the primary languages that we serve in our area. And that may be also similar to some of the newcomer populations in your space. I don't, unfortunately, have Swahili if you're in the Columbus area or other pockets throughout the state. And our goal of this was to help families really understand what's going on, and then also understand what they wanted to do. And pairing along with our video resources, we developed some pretty simple handouts. Lead, what's the problem? Who's at risk? What effects am I worried about as it relates to lead? And where can I find it? And we tried to kind of quickly summarize that, but also make it visually engaging so that families could kind of quickly know, all right, this is what's going on with this problem. And these were resources were also translated into those languages that I discussed earlier. We also wanted to know, quickly, what should I do? I should clean the house and dust and mop. And we talked about some of that. And we actually talked about all 3 of those cleaning supports, encouraging people to get in to talk to their healthcare provider, understand a little bit more about their home, and then a focus on nutrition. The big piece of advice as it relates to, talking about after we get over talking about where can you find lead and what can you do about it? How often are we going to be testing your child, and what level do we need to be thinking about medications for your child? It's really a focus on what is your child eating? And it's not that you can eat your way out of lead exposure. You can't. And to be very clear, that's not the goal in talking about nutrition. The goal is talking about what else can we put to maybe mitigate those risks. So if you're iron deficient, you're going to have more pica-like behavior. You're going to be seeking out more non-food items. And we really focus on iron, vitamin C, and calcium intake, appropriate levels of calcium, and appropriate sources. And we try to show families really what are some good examples of foods that they can look after. But again, you're not going to eat, you're not going to fix your anemia in order to reduce your lead level. We need to get that exposure reduced in the first place. The next, so we did 2 handouts, and again, each of these translated. The second handout was really more a focus on patient's home, and we kind of took a checklist approach. Here's what you need to think about, and this is where our legal aid partners really came into play, and did a great job, I think, of condensing what is sometimes a difficult topic around lease and lease arrangements, and what are my rights as a tenant, and what should I do, if I'm looking for a house. Those sorts of things. And then we also tried to break up our resources in terms of what do you do if you rent? Is that different than what you would do if you owned a home, and what are your responsibilities? So that really is our story of what we've done with lead and lead exposure, and lead screening, and kind of taking that into the clinic, but also taking that into the community. We've tried to work with our community health workers we developed a community health worker curriculum that uses the video and these handouts, and in about 2 hours, 1 hour sessions, working with families inside of their homes to help them go through their house and identify potential risky sources and identify areas that they could improve on reducing their risk, even just understanding things like how old their home is, or what kind of damage might be present that they might need to address, or how to talk about those issues with their landlord. So I put on the last slide here some of those additional resources. Again, we are very fortunate in Ohio to have a lot of people that are interested in helping kids reduce their exposure to lead. I put on here the Lead Free Ohio link, a link to the Ohio Department of Health, excellent resources there, and will be more coming soon as we think about some of the guidance that's changing with the new CDC guidance. Our lead clinic resources, and then a little bit of information about lead in water, because that often comes up as a topic of conversation that families have. So at this point, I'm going to open it up for discussion. I thank all of you for being here, and I'm already monitoring the chat. There's been some excellent questions that have come through as I've been peeking at that. But that's the end of my formal presentation. I think we'll enter into a time of discussion. Alex, do you have any specific themes from the chat that you wanted me to discuss to start off?
Dr. Davidson, there's a question about a partnership with WIC regarding increasing screening rates.
So the answer to that is yes. WIC can be an important provider, for an important touch point where we could get some screening results, some lead levels from kids. And there, in our area, it kind of depends on your local health department, and who is really willing to kind of put together the standing order that's associated with that assessment. I will say, from an information exchange standpoint, as you're talking about the lead level that gets done at WIC, what happens with that test result and where does it go? Certainly anyone that's doing lead testing has an obligation to communicate those results to the state. Our lab does that very consistently. And then the state is able to the state Ohio Department of Health is able to see that information and contextualize it and bring it back. But I think one of the challenges of thinking about, additional settings of lead assessment, whether you're thinking about a WIC office or a preschool or even like a home-based program, is what's the workflow of who receives that result, who's responsible for actually taking care of the result when it's positive, and who's aware of that, and some of that's where some of the interoperability things come into play as it relates to state impact SIS or some things that we communicate, even like how we communicate immunizations, or one computer system in the state talking to another. CliniSync is kind of another big partner throughout our state that can help us to kind of exchange that information and make sure that additional providers for that child or family are knowledgeable about what that result is.
I have a question for you. One of the resistance I sometimes get from parents is they say, I've already had my lead screening done at WIC, but we don't have any way to access WIC results in a private practice. So have you had any experience with this or ability to be able to work between different institutions to make that lead screening results that are available more visible?
So I will say, even just in the last 6 months, we have been able to kind of turn on some of that interoperability, external results viewing. Another challenge on the electronic side is not just can you see it, but is it part of your system? So one of our challenges that we're even working through now is I can see some of those external results from some of those key identified areas that we knew were high utilizers or kind of high overlaps with us, but I can't build that into our electronic workflow. Now, it kind of depends on where you are in your own journey within your office. I mean, the question asker kind of brought forward in a private practice setting, you may just have to have a kind of rote way that you're able to identify that. Like, well, did they tell you what the result was? And if they tell you a number, then maybe it's true. If they don't, I think it's also challenging not seeing that, because sometimes families may think that they got one thing when they really didn't get that thing. And so you probably need to talk to your WIC office about how we can communicate those things effectively. But the interoperability, I think, is still a challenge. I'm going to phone a friend, actually. I see that Dr. Newman is on. Dr. Newman, if you would like to unmute and talk a little bit more, if you know any more to answer this kind of WIC integration question, especially as it relates to our visions around, or visions of what's actually possible around the like impact CIS reporting of lead results, for example.
Yeah, we have a large EMR. We have EPIC, which almost everybody in our region does, but I don't think WIC uses that when they're reporting the results. So I can see lead screening results from a whole lot of different hospital settings in my region, but just not WIC.
Yeah, so my understanding, and this is from like communicating to ODH, that there's not any like consistent lead testing being done at WIC offices. There was a project years ago that was funded by EPA, and that when that funding was cut, most of them stopped. One potential example, because I'm in Cincinnati, is the WIC offices in Northern Kentucky will do a lead testing because they still kept their old lead care 2 machines with, like, the caveat that there's been problems with them. But they only will test children who have no insurance. So, which is kind of a weird situation, because if you're going to the WIC office, you should be able to qualify for like Medicaid in Kentucky too, but there's other things. So, and then Chris Alexander's on, so he may want to comment, but like all of the lead levels are required to be reported to the state health department, and that's how they end up in impact CIS. And if your EMR has or electronic health record, or whatever we're calling it now, has interoperability with impact CIS, you could potentially get that like data flowing back to you. Our system isn't quite configured that way, although we use EPIC. I think one of the problems with EPIC is like there's thousands of installations of EPIC, and there are thousands of installations of EPIC. Like no one is the same. It's not like your iPhone where like they update the operating system and everyone gets updated and it's pretty much all the same. EPIC, you can have EPIC, but everywhere that there's EPIC, it's different. And so that's one of the challenges of interoperability. And I think the WIC problem, like, is very interesting because in truth, like there have been a number of studies showing that like the best way to get lead levels drawn, if that's like your goal is to do lead screening, is to do it through the WIC office. But since that funding dried up, that's really dried up too. And I'm sorry, I should have started by like introducing myself and thanking you, Dr. Davidson, for such a like great talk. And I love the quality improvement work that you've done and really made it. You show like how like this is really possible, and I think that's really, really great. I am a pediatrician, and I'm also trained in occupational medicine, and I run the environmental health clinic at Cincinnati Children's Hospital, and I've been part of a whole bunch of lead initiatives for years in Ohio.
I'm going to transition to the next question that came up in the chat, which is, what about community partnerships? We have some excellent examples of community mobilization efforts that really have improved, kind of how we think about this. Lucas County, I think, has been a foundational leader in thinking about what a lead coalition looks like, and how do you work with various stakeholders that have lots of different interests within this topic, and bring all those people together to as a community meaningfully move forward. Cuyahoga County is doing something similar. I'm not as familiar with the southern part of the state in terms of that kind of a coalition. I would say, we still have some work to do in Summit County, in the Akron area. And some of that has to do with how we look at housing law. Some of that has to do with, the sheer just amount of time that it takes to put some of those things together. So, I think that there is a lot of really great work that can happen as you think about community partnerships. In Ohio, we've got a couple of Help Me Grow workers even on this call. And the reason that we have that is because we've made that a qualifying condition for early intervention services, that if a child has a lead exposure, they are eligible for those services. And I think that that's an important intervention. And so the issue of lead and our advocacy related to it absolutely relates to how we manage those different stakeholders. We make sure that we're paying attention to what they're bringing to the table, and understand where some of their challenges are. At the end of the day, some of this is about poor housing stock, and that's where this problem becomes a very expensive billion with a B, problem. But at the end of the day, what we want to do is create healthy environments for kids to grow up in. And I know that that's the right way to approach it. And if we can do that for kids, then they grow up to be healthy and productive adults. That's kind of the take home message. So if anybody wants to add anything else about community partnerships, you're welcome to chime in the next couple minutes.
Maybe just to put an exclamation mark on your last point. Yes, it's an expensive problem to fix, but the research would suggest that for every $1 spent on lead poisoning prevention, it pays back to society about $17 at the minimum. And so it's a good investment. The problem is that people have to be willing to think that way. And we have made a lot of improvements, but I feel like we've hit a bit of a plateau.
And I think that that's an important part of these discussions is keeping, some of those efforts at the fore. And yes, Nick, thanks a lot for bringing that up. Like I said, it was an expensive proposition, but it's actually expensive to ignore it. The other practical question I think that was in the chat was, did we see a large number of elevated leads when we started increasing our screenings? No, we didn't. It's kind of amazing that things track along averages, and especially when you're talking about large numbers of kids. Certainly, you do have a few more kids that you've identified because they're there. But that's a good thing. That's what we want to do. We want to be able to find them and intervene and kind of continue to push some of these issues. They're there whether we test them or not. And, it was not debilitating in terms of our ability to respond, but some of that's how we structured it. We knew going in that we were going to screen more kids. We knew that we had a structure under which to plug those kids in to the right resources. And I would say, if you don't have that robust institutional buy-in, that's okay. There are folks of us that are willing to help, and really throughout the state. And you can help even just as a practitioner. You are able to learn these things, and we can certainly be there to help you to communicate what is needed for your patient.
Great, thank you. Thank you, Dr. Davidson. Are there any other last minute questions? I know we're at 11:59, but anything else that you'd like Dr. Davidson to touch on? Thank you, everyone who asked questions and contributed to the conversation. I think this was a wonderful training. And thank you again to the Ohio Department of Health for their support and collaboration with this training and the Lead Free Ohio program. There's one more question, Dr. Davidson.
That's a great talk for that's another great question for the next talk, which is what do we do when kids really have a high lead level, and how are we gonna move them from their houses? I'd love to hear about somebody who solved that problem.
Yes, and I will send out the links that Dr. Davidson posted, and I also have a link. I'll send out the slides and the link to the training as well, and that'll all be in the email on Monday. Thank you for asking. Anything
Thank
else,
you.
Dr. Davidson, before we wrap up? I think that's everything. Thank you so much, Dr. Davidson, and thank you, Dr. Newman, for jumping in, and everyone else. This was a wonderful talk, and so glad we're able to kick off the new year with it for the lead program.